For joining. This is the eighth webinar in the WHO Responsible AI webinar series hosted by WHO CRO and KCDH-A. We are starting shortly. Dr. Meenu to join. Let me give a small introduction about the webinar series, which we have been doing for the last many months, and it's almost a year that we have been doing this. So this is the eighth part webinar of the year-long webinar series, which we have been doing along with WHO CRO. WHO CRO and the Koita Centre for Digital Health at Ashoka University has been hosting this webinar series, which is essentially aimed at sharing insights from all across the Southeast Asia region into what's happening in the healthcare AI space. As we all know that AI in healthcare is coming up very rapidly, and then while we can debate whether it's a boon or a bane, what we cannot refute is that AI is going to play a significant role in delivering healthcare in a country like India. Yes. Welcome, Dr. Meenu.
Thank you. Thank you so much. I was a little late. We were having some PhD doctoral committee meeting. Got
No
a little
worries.
late.
Yes, so I think we have a houseful audience, and maybe I'll quickly give an introduction about Dr. Meenu Singh, who is the Executive Director and CEO of AIIMS Rishikesh, and she like Rishikesh, especially AIIMS Rishikesh, has been a pioneer in delivering last mile healthcare delivery to like the rural areas of Uttarakhand, and also she has been a pioneer in helping us deliver cutting edge and specialist healthcare to different parts of the country through eSanjeevani, which is a telemedicine platform of India. And she will be sharing more about what she has been doing. But we have been following very closely about the different news coming from AIIMS Rishikesh about your various initiatives like the heli ambulance and the drones, and how you have been spearheading so many different initiatives to reach Uttarakhand's most remote terrains. So, welcome, ma'am, and we are looking forward to hearing your keynote. We also have two fantastic panelists with us. We have Dr. Neha Verma, who is the CEO and co-founder of IntelliHealth, which has been spearheading last mile telemedicine for India and to the rural places. And also we have Dr. Geeta Manjunath, who is the founder of Niramai. Many of you might already know about Niramai, but like she will probably touch upon more about what they are doing. And most importantly, they have played a very important role in reaching to the rural areas where we have lack of radiologists and specialists who can help us diagnose breast cancer for the population. So without much ado, maybe I'll request Professor Meenu Singh to share her insights and what she has been doing at AIIMS Rishikesh with eSanjeevani and what she has in mind, her vision for the country. Over to you, Dr. Meenu.
Thank you very much. I'm really thankful to Ashoka University and the WHO CRO group for ICT for inviting me to make this presentation, which I think will be of interest to people who have been involved in doing teleconsultations, telemedicine. And today we are going to be talking about and looking at various technologies, especially AI, how that is helping in telemedicine. That means remote healthcare delivery. And I will be, can you share my presentation? Yeah. So basically, we have been doing telemedicine through eSanjeevani platform, and we are using other platforms as well. And eSanjeevani, as you know, it is a government-sponsored scheme which is free to the patients. It has three components. It has a eSanjeevani Health and Wellness, which is now being practiced in the Ayushman Arogya Mandirs. There is a eSanjeevani OPD, which a patient can to a doctor and take a consultation in which you are seeking consultation from a super specialist in places which are tertiary healthcare centers. So we will be talking about AI, how it is helping in last mile healthcare delivery, which is through telemedicine in many of these areas. As we know, telemedicine leverages digital communication, and these days it is even called digital medicine or digital health, because now it is no more tele, it is on every screen which is available, including mobile phones. And it also involves transfer of data through electronic medical records. So it leverages digital communication technology to deliver healthcare services remotely, improving access to quality care regardless of geographical location. So the core components of teleconsultations are video and audio consultations. Then we have mobile health applications. We have remote patient monitoring, which are wearables and IoT, Internet of Things. We have electronic health records, and we have secure health data exchange. So these are most of the things which are happening in telemedicine. And we, of course, need a very enabling kind of a network for accomplishment of these requirements. Now, how AI is involved in healthcare? We know AI is now in all fields of healthcare, and it is not only guiding patients or doctors about what to choose and what to use in a particular patient, depending upon the diagnosis, the setting, but it is also steering way in interpretation of many investigations, which could be radiological, which could be pathological, which could be any other biomarker related. The key AI technologies which are used are machine learning, medical image analysis, natural language processing, large language models, which are now become very popular, predictive analysis, and clinical decision support systems. And AI augments, but not replaces, clinicians by enabling faster, more accurate, and evidence-based clinical decision-making. So the way AI can be used in telemedicine is that it is a diagnostic assistant, which is like, all these days you have assistants which help you in, various telephones. We have Google Assistant, we have all other type of assistants which are there. So it also helps in the diagnosis. And this actually diagnostic assistance is based on data which is available. And on the basis of that data, we try to develop a diagnostic algorithm, and which could be used in a continuous way, and we can make a diagnosis, and at every step you can get help from AI. Then there is something called as virtual triage. We know that when a patient meets with an emergency, which could be an accident or it could be a disaster, you need to interpret all the data which is available on the patient, which is in the form of symptoms, signs, radiological investigations. So from a remote end, one can perform what is known as virtual triage and plan and decide about the treatment which has to be given to the patient on the spot. So for that also, we transfer the data digitally using in telemedicine, and that kind of guidance to the patient or the health worker or the nurse can be given to these patients. Then we have situation of remote monitoring. We know that these days a lot of devices are there, which are wearables, and one can see sometimes what is the saturation of the patient, what is the blood pressure of the patient, what is the blood sugar of the patient. There are many devices now which are available, and some which we have been using is First Slate. We have also been using a suitcase model of telemedicine in which you can perform all these tests, or a backpack kind of a telemedicine in which a person on a motorbike goes into the community, performs the tests, and then those tests can be reflected back onto the expert, and some consultations can be given. Similarly, ECG can be, done, and that is also remotely communicated to the, say, a health center or a hospital, and to a consultant, and diagnosis of myocardial infarction or whatever chest pain the patient has been having can be made. Then we can do predictive analysis depending upon how the patient's monitoring has been. We know that there are certain smart homes in places in Scandinavian countries, they are there, and especially in geriatric population who cannot move in and out of the house very often. So the devices are placed in their environment and even embedded in their structures, and they can monitor their movements, they can monitor their uh, other parameters like blood pressure, sugar, and one can actually predict from this data how these patients are going to be doing in future, and also treatments can be given to them. So AI powered wearables are there. We know these days everybody is using smartwatches, and these smartwatches are actually calculating and telling us what is the risk of developing a particular condition depending upon what parameters are being measured. Similarly, there are many other smart materials which have been devised which can detect the signals, and they are sensor based, and analysis can be done on them. Now, after this, there is a proper teleconsultation which takes place. And in a proper teleconsultation are these platforms which are used, like ECGP we've been talking about. And there, the electronic medical record of the patient is shared with another doctor, which could be like a point-to-point consultation, like doctor-to-doctor consultation. But sometimes the patient himself or herself can also give a small kind of data which is recorded on a performer, which can be communicated. And in other situations, doctor themselves can talk to the patients on video call and converse with them. And there are several devices which can again be used. There are things like electronic stethoscopes which are now available, which can remotely monitor patients and tell us whether there is a cardiovascular condition or there is a lung sound which is abnormal. So that can be communicated to the consultant, and a proper consultation can then be done. Radiology in this actually plays a very major role, and these days we have CT, MRI, plain chest X-rays, digital X-rays, ultrasounds. These are video recordings which can also be communicated through the databases, or they are communicated as such through networks, and the diagnosis can be made. And where AI comes in this is because AI can be used to report on these chest X-rays or other radiological investigations, because sometimes it takes a lot of time for the consultants to sit down and look at those X-rays or CTs, and it takes more time, and that delays the diagnosis. Whereas with AI, there is a reduction of about 80% in this time which is required for reporting, because the AI systems can report radiological or pathological specimen, the reports on a much faster way. Then there is management of patients, especially medical management, because medical management means you have to give these patients prescriptions, you give drugs to them. And of course, through telemedicine, you cannot deliver drugs, but you can do that by using systems like UAVs. We have drones which can carry medicines from one place to another, say from a hospital to a home, where the treatment is given to the patients depending upon clinical condition. Along with that, we also indulge in rehabilitation, and rehabilitation is required in neurological patients who've suffered from stroke, or those who are developmentally retarded, or those who have cardiovascular problems after they've had their surgeries or their interventions. They need rehabilitation. Now, for rehabilitation also, now there are different systems that a doctor is not always expected to sit and advise about rehabilitation. There are chatbots, other things which can be followed by the patients, and they're quite interactive as well, in which if the patient is improving over a period of time, then the exercises or interventions, they can be modified. Then there is something these days which is called as a digital twin, which is being used. And like for, say, there is a patient of diabetes, and you want to create that patient's digital twin to test what other medications can be used and would have an effect on this particular patient system. And those are now being increasingly used in medical management of patients. Next. So integration of AI in telemedicine is that there is a patient community or a health worker, there is a teleconsultation, there is AI-based screening and risk prediction, which could be based on image analysis with NLP or predictive models. This is all AI-enabled telemedicine workflow. After this, one introduces a clinical decision support system, which can tell what to do, what not to do in a particular patient for diagnosis as well as for treatment. You can have a remote specialist consultation if you're not very satisfied with the basic consultation which is being given by the system. And then you have treatment and e-prescription, about which I've just talked, and we can have remote monitoring and follow-up of these patients. And after all this leads to population health registries and analytics. And benefits of this kind of treatment are that there is a reduced travel, there is a faster diagnosis, and there is a better referral, and there is definitely cost reduction. And many studies have been done which have shown that these techniques are quite cost effective. So what happens in an AI-driven clinical decision support system, say in telemedicine, an AI-powered clinical decision support system assists healthcare professionals during telemedicine consultation by analyzing patient data, which comes in the form of electronic health records, medical history, vital signs, wearables, laboratory results, medical images, symptoms, generating evidence-based insights, and supporting timely clinical decision-making. So there can be an AI engine which tells us about the risk prediction and stratification, disease screening and diagnostic support, medical image analysis, clinical guideline recommendations, personalized treatment suggestions, as well as drug interactions and medication safety checks, because sometimes you use medicines which may have interactions, and by using AI, one can quickly check whether there is an interaction or not within the two drugs. So similarly, this clinical decision support system will assist the diagnosis. It will prioritize patient triage. It will cause referral recommendations, e-prescription support, and follow-up and remote monitoring of the patients. And it can also lead to remote clinician reviews with the AI insights. It confirms the diagnosis and treatment, and provides virtual consultation and continuity of care. So this is, say, for a diabetic patient, this is the clinical workflow in which AI is integrated with telemedicine. So the patient is undergoing home monitoring with the help of a wearable or a glucometer. There is AI analytics, which will tell about glucose prediction, HbA1c estimation, complication prediction, and lifestyle risk. These days, there are several monitors which are available, and these sensors are just inserted subcutaneously, and they measure continuously the glucose levels. After this, there is a teleconsultation with an endocrinologist, dietitian, or a diabetes educator. There is a digital prescription about drugs, what has to be used, how much exercise, what food, what lifestyle changes. Those have to be taken off, and then we continue to remotely monitor these patients. Next. So another way of picking up complications, say in diabetes, there is diabetic retinopathy. So one can use a fundus camera, and through the AI, it goes to the teleophthalmologist, and one can pick up all these problems which can occur in these diabetic eyes. There is a remote ophthalmologist review, and treatment recommendations may be there. And of course, there will be a follow-up screening of these patients. So these patients can be screened at primary healthcare facilities or in vision centers or mobile clinics without actual requirement of an ophthalmologist. It is just a health worker who can use this fundus camera and pick up images. There was something called as Madhu Netra, which was designed by All India Institute of Medical Sciences, Delhi, in association with AIIMS Rishikesh, in which one can pick up the diagnosis of diabetes and the status of diabetes by looking at the fundus of these patients. So the ecosystem across the disease is somewhat like this. In, say, oral cancer, there will be an image analysis, there will be tele-oncology, early cancer detection. In diabetes, there will be risk prediction, tele-endocrinology, continuous disease management. Say in breast cancer, we have Nirmaya, because Nirmaya has actually been using, I think, heat-based breast cancer screening, in which mammography AI would again be done by teleradiology, a faster diagnosis. Similarly, in renal disease, there will be fundus picture through retinoscope, and teleophthalmology will be there. In renal health, there is chronic kidney disease prediction, telenephrology, early management. Similarly, in mental health, there is risk stratification, telepsychiatry. We know there is a tele-mental health line these days available, which is being run by NIMHANS in Bangalore, in which anybody can call this telemanas and get a consultation. Similar things would happen in neurology, where multimodal neurological AI is used for precision neurological diagnosis. So there is another science now, transplant science, in which organs are being transplanted. And there also AI is proving to be of great help. So AI is framed as a new digital layer for transplant care because transplantation requires complex data heavy decision before and after the surgery. So there are several studies which show better prediction or automation performance than conventional scores in selected tasks. And there are some reviews which highlight allocation and matching transplant patients, which could be even transplant oncology, immunosuppression, and pathology as the major domains. Of course, external validation is needed for many of these systems, and their reproducibility, workflow integration, etc., has to be demonstrated because they have been proven to be of key bottlenecks. So how it does is that it helps in allocation and matching, because in transplant science, one has to match patients before they are, because HLA matching has to be done before a transplant is done. So if a database is available throughout the country, the matching becomes easy and finding a donor also becomes much easier. In transplant oncology, predicts tumor recurrence and post-transplant survival using richer pre and post-operative variables than classic morphology-based criteria, as happens in, say, bone marrow transplants, where patients are suffering from malignancies are used. Then there is immunosuppression, because every patient who undergoes a transplant has to go through immunosuppression to avoid rejection. And in that, adaptation using genomics, lab follow-up data, and biomarkers is something which is helpful with the help of AI. Then, of course, is digital pathology, in which automatic biopsy interpretation, steatosis, quantification, and tissue classification are used, where specialist pathology capacity is limited. So why transplantation is ideal for AI is because there are complex decisions involved here. There is a time pressure and there is a rich multimodal data, which is there, which has to be used for these patients. Now coming to AI-enabled last mile healthcare delivery. We know that patients are in villages. We can have a telemedicine camp in which we are looking at these patients. We can have a teleconsultation with a doctor who is stationed in a super specialty centers. These super specialty centers may be located in any of these places like AIIMS Rishikesh. We have a telemedicine van as well. And then we have e-prescription and medicine delivery, which can be done with the help of, there are certain agencies now doing net medicines, and then follow-up care is done. So centrally, AI would be connected to PHC and health and wellness centers, to mobile medical units, to eSanjeevani, specialists at AIIMS Rishikesh. We send this data to ABDM Cloud. ABDM is Ayushman Bharat Digital Mission Cloud. And then, of course, it is combined with medicine delivery. So these clouds are actually health stacks in which all the data is getting stored. And this data is ultimately used for developing AI tools. So I would just like to show you what we are doing at AIIMS Rishikesh. We have certain facilities. This was our telemedicine center, which was inaugurated by Honorable Health Secretary in August 2023. We also have a Center of Excellence in Artificial Intelligence since August 5, 2023. And we have been collaborating with the Wadhwani Institute of Artificial Intelligence and IIT Roorkee. And now we have also established a collaboration with IIT Ropar in the field of AI. So there are several departments which are involved in AI projects, which include radiation oncology, radiology, pulmonary medicine, dermatology, ENT, ophthalmology. Many departments of the institute are involved in this. We also had some CSR initiatives by HPE, in which Some labs were set up for AI, and our our researchers have been using these labs for developing tools for AI. We have regular meetings with the project's investigators of AI in our Center for Artificial Intelligence. The project deliverables are mostly in these fields. Right now, we have diabetic retinopathy, anterior segment, dermatology, in clinical decision support systems, and many new use cases are being developed by our doctors. In health, we are using AI for diagnostics, telemedicine, predictive health, and for personalized medicine. And through eSanjeevani, we are doing teleconsultation. Here, a teleconsultation is being done through eSanjeevani in one of our consultation rooms. We also have health outreach by drones. Drones, as you know, are robotics. It is also a form of AI in which the sensor-based technology is used, in which the drones are programmed to go to a particular coordinate, and they take medicines over there. And we have been sending anti-TB medicine to some of the homes which are otherwise very far away, and otherwise patients have to come to AIIMS Rishikesh to collect their medicines. So that has been found to be very useful, and Honorable Prime Minister also tweeted about this endeavor by AIIMS Rishikesh. This does it work? Getting done? Now the drone has landed back after delivering at a peripheral center in Diri. And there are several future scopes of drones. By using artificial intelligence, we can, and obstacle avoidance and real-time decision making, multiple drone operations which are covering large areas and faster and improving missions. We have used drones also for spray of insecticides, which can be used in fields where insecticides are sprayed along, and also in dengue prone areas where there are mosquito breedings, there also insecticides can be used and sprayed on some of these. So helpful in disease control centers and communication networks. This is our health outreach by mobile van. This is our telemedicine van in which patients can be seen sitting inside. We have several of these equipments which are available, and patients are these are point of care devices which are being used for measuring the pulmonary function of the patients, and also blood pressure and blood sugar, etc., and many other parameters which are measured. So we know that in telemedicine, AI has a lot of future, and it is expected to transform telemedicine technology. But we certainly need enhanced data security and privacy to strengthen the cybersecurity and privacy measures to protect sensitive patient information. We must have ethical AI and regulatory compliances, which are developing robust regulatory frameworks to ensure the safe, transparent, and responsible use of AI in healthcare. So these are some of my thoughts today, and I would be open to questions and comments. I purposely did not show heli ambulance because that is basically being used for patient transport, but AI is used in there for teletriaging of the patients, because once the AIIMS helicopter goes to places where there's been a disaster, one has to triage the patients, and that is where telemedicine and AI is used. Thank you. Thank you very much.
Fantastic, ma'am. Thank you so much for sharing with our audience like the very inspiring initiatives which you have been spearheading at AIIMS Rishikesh. And of course, I mean, I have been to your campus multiple times. It's a fantastic campus, and we are aware of the fantastic initiatives which we are doing. So for the audience, I see a couple of hands. We will not take live questions. So you can put your questions in the Q&A section. So at the end of the panel, we are gonna answer those questions. And if panelists can answer any of the questions, like while the panel goes on, please feel free. The rest of the questions we'll answer live. So I think we can move to the panel discussion and welcome Dr. Neha and Dr. Geeta Manjunath. And so I will ask the first question to Dr. Neha. And so, Dr. Neha, I mean, can you tell a little bit about the initiatives at IntelliHealth which you have been doing? And you have been reaching out to a lot of these underserved areas, right? Which often have significant barriers when you try to population. So, how do you see what are the opportunities for AI to help you reach out to the last mile?
Thank you so much for having me on this panel, Dr. Datta. It's a pleasure to be here and share a little bit about our work. So, in our experiences, IntelliHealth has been supporting telemedicine programs in India, in Indonesia, Nepal, and in Kyrgyzstan. And in India, we are supporting the eSanjeevani program in the states of Karnataka, Jharkhand, Odisha, and now Madhya Pradesh and Chhattisgarh at a statewide level. And we see so many opportunities really for the use of AI to strengthen telemedicine care delivery. When you think about why AI is necessary in the scope of telemedicine care, it's that I think one of the biggest reasons is improving the quality of care. So telemedicine improves healthcare accessibility, but as we know, when the healthcare accessibility is improved, the number of patients coming into your system goes up. So someone living in a rural village who was not able to access healthcare previously now kind of does not delay seeking care and comes to a community health officer to do health and wellness center assisted consultation or uses the OPD app to do the consultation from their home. And so all of a sudden you have more patients entering into the system, but you do not have an corresponding proportionate increase in the number of doctors in the system, right? So we know that, in overburdened systems, quality issues occur. Even in the best of systems, quality issues can occur. So AI has a really wonderful scope, and that's really the work that IntelliHealth is doing. Building tools, AI tools. And when I say AI, I don't just mean large language models. AI is such a generic term. It's like saying vehicle. Do you mean car or bus or train, really? So large language models is just one type of AI. There are lots of other types of artificial intelligence that can be used in the scope of telemedicine. Dr. Mino's presentation very comprehensively covered all of them. So I won't spend time talking about it. But at IntelliHealth we have been building clinical decision support systems. Given the vast amounts of data that IntelliHealth has through its programs with NGOs, aside from government, we also work with a number of large NGOs to provide telemedicine services. And based on this, we have built a clinical decision support assistant that uses a combination of large language models and classical machine learning techniques to provide diagnosis decision support. Well, the first step is it guides the patient to take a history the way a doctor would take a history. So rather than there being a 20-minute long teleconsultation, you're task shifting the history directly to the patient or to the frontline health worker. We've published research that shows that this assistant gathers 75% of the history that is captured in a medical consultation. We partnered with Vadzani AI and AIIMS Rishikesh to deploy this digital assistant into eSanjeevani, really with Vadzani AI spearheading the work and CDAC leading it to deploy the rules-based history-taking assistant that's now available in eSanjeevani. We've also built tools for using large language models for diagnostic reasoning. Randomized control trial we did showed that the use of a diagnostic decision support assistant improves quality of diagnosis by 12%. It improves a quality of medication prescriptions by 43% by reducing unnecessary antibiotic prescriptions, prescribing more generics, more prescribing practices that are more aligned with the essential drug list of what's available in a health and wellness center. We're partnering with various groups to bring in AI point of care diagnostics. All of this is aimed towards the fact that in teleconsultation, the only data source is the history and whatever visual images you can capture in the absence of a in-person face-to-face physical exam. So I'll stop there. The list can go on, but these are some of the ways that IntelliHealth is working and some of the benefits of why telemedicine needs AI.
Right. Thank you, Dr. Neha, for sharing what you have been doing. And with that cue, I'll bring in Dr. Geeta Manjunath. And Dr. Geeta, you have already deployed your solution, which is a non-invasive breast cancer detection solution. And you have reached out across India and, of course, many different countries. So, how has that experience been in being able to reach to the masses where we don't have specialists in the country? And how do you build trust in the communities where you're deploying your solution?
Yeah, sure. First of all, it's very nice to be on this platform. I mean, always had a huge regard for Ashoka University, and Dr. Meenu ma'am is here, and Dr. Neha. Huge congrats for what we've done in IntelliHealth as well. So, and great to be with you, Dr. Savarkar. Yes, at Niramai, as many of you know, we've developed this new method of detecting breast cancer. We've been focused on solving this one big problem that is killing 2,000 lives of women every day, right? So I've been sort of stuck on this. How can we stop deaths due to breast cancer? And as a technologist and sort of seen so many 100+ AI solutions that we built at HP and Xerox in my lab, I know that AI can do multiple things. So we started off with this huge problem that needs to be solved, and how can AI be used, right? And as you again know, while we do have AI in mammography that we have built ourselves, people are not taking mammogram as much as they should. Like, in India, there's a paper from Dr. Rajendra Badwesar and other and his team, where they showed the mammography usage in India is just 1.3%, so as opposed to 76% in UK, things like that. So when that is the case, we mapped out, and for the exact reason you said, especially in rural India and especially even in urban India when people are not using it, how can the current methods be affordable and accessible? So what are the key problems, that exist in the current solutions, and how do we address this gap, right? So affordability, accessibility that we talked about, and the experience of doing the screening should be comfortable, especially, again, rural areas. Removing clothes, getting touched by somebody else is something that, unfortunately, our women are not so comfortable with. And again, there's also the issue of younger women getting affected in India, where, the current tools are not directly usable. So at the end of the day, it becomes that hand becomes the tool to detect cancer. And hand can detect 2 centimeters, 2.5 centimeters, and it sort of ends up being stage 2, 3, 4, whatever at the time she actually figures out that there is an issue. So yes, we've developed this, as Meenu ma'am also briefly mentioned, a new method where we just use a thermal sensor measuring the temperature variations on the chest and convert that into a cancer health report. Coming to the point that you asked, right? So when we look at how these kind of AI-based thermal scanning tools can help women in the rural areas. First and foremost, right, it has to be affordable. It has made the affordability almost 10% of the current cost of delivering such a service, with huge machinery going there, etc., etc. That is, you kind of make it much more affordable. It is portable. I just happen to have it on my table. This is the kind of device we're talking about. It's really, really portable, handheld device. So you can put it in a backpack, take it out and do the screening anywhere, right? So that is very, very important part of the solution. And then we made the user experience really, really good, where we create a changing room-like experience. We have 4 curtains. The lady enters. Nobody is inside. It's just a small booth, like literally a changing room in a mall when we go and try out new clothes, kind of a thing. Exactly that type, right? So she goes in, she has to remove clothes, but no one sees her. She sits in front of a device like a passport photograph. And that's about it. Just because people wear very tight clothing at that area, we make her sit for 5 minutes without anything. I mean, she can move and all, but just with some cool air being blown. And after 5 minutes, we take 5 images and ask her to wear clothes. By that time, the result is available. So it makes it so simple that no one sees or touches the person during the test, right? So she feels very secure, very private, and we see huge adoption, wherever we go because of this kind of experience-based preventive healthcare, right? And then, of course, because we are looking at reducing the operational expenses also. So we can't have doctors, doing these camps, unfortunately, right? We have low resource, low skills there. So we make the tool more usable by a low skilled health worker. And the result is also just saying red, yellow, green to start with, so she knows, okay, kya karna hai? So if it is red, then she knows I need to call the doctor. It could be a telehealth setup like both Dr. Neha and Dr. Meenu ma'am mentioned. And in fact, we have a couple of health kiosks where we have integrated this, first ever time a women health pod, has been integrated. And we are hopefully working towards having more of them. And so with that, what happens, you can also talk to the doctor, but at this point in time, the doctor gets the report and the person is sent for the next level diagnosis, which is usually available in a CHC or a district hospital, which is an ultrasound, mammogram, MRI, whatever is needed. But the good part is if you screen, let's say 100 people, maybe 5 to 6 people only need to go to the next level testing. So 94 people among these 100 women who screen can be happy to say that they're good. For this, some of them, I saw some questions about how do we sort of validate, and that's a huge, huge important part, right? We validated the test with retrospective, first lab level testing, then retrospective analysis, prospective analysis, field-based analysis, real-world analysis, and also kind of a randomized way where we compare with how best does it perform with respect to clinical best examination. We tested on different, like South Indian patients, North Indian patients, Northeast India, Indian patients were kind of a different demography. Not only that, we tested in European population, African population, small US is a small test we have done. Everywhere, we need to sort of, first of all, for the training set, we need to have that. But more importantly, your test has to be sort of not dependent on features which are likely to be demography dependent. You can't have it for every model, but because our model itself is based on tissue activity, which is temperature is a proxy, vascular activity, where we are able to extract those structures from like a thermal map. For every person, we measure 4 lakh temperature points, almost close to like every tissue ka temperature kya hai. And we have 200 millikelvin thermal sensitivity. That is 36.02, 36.04, 4 millimeters apart, we are able to make out, right? And do the analysis. So having these kind of high sensitive sensors, highly sensitive and precise, if you want to call it, and enabling it takes care of the accuracy and generalizability of it. But coming specifically to responsible AI, right? One is taking every decision during the training, testing, deployment, and all of it with the user in mind, right? End user in mind, and how it may affect the comfort or the accuracy. So making sure that it doesn't, right, affect the comfort or accuracy system. So for example, every release of a new model that we do is going through what we call as engineering change notification. We are ISO 13485, right? And some of them, in the audience could be an SAMD. It is an SAMD because we don't make these devices. These are available. And we have the software which converts temperature map to cancer health report. So for every release, we actually have a criteria that it should not affect the sensitivity specificity by more than some very small 1 or 2%, as per the rule itself. So you ensure responsibly you retain the accuracy, even if you need to change the model. This is locked models, going through the regression testing, etc. Second, the models are transparent enough so that a human can come in and see what's happening during the process of decision making. And this is my own list. It's not like a theoretical one. I'm sure there will be a connection with it. And so for example, we have a technician who's trained a bit. We do a segmentation check in the beginning, like automated analysis of where the breast is and so on. So obviously the technician can see whether that is good or not, right? So wherever technician's human review can be done, we give, like for example, which view of the breast of the person it is, so she can make out. But yes, we have about 25 different machine learning models. Combination of that, we have different checkpoints during this decision making where a human will say yes, go ahead. So that is a mandatory process for the regulatory piece. And finally, when the report is generated, first we make sure our negative predictive value is very high. What is negative predictive value? When we say no, it's a no. Pretty much 100%, but yeah, over 99%, negative predictive value being very, very high is important. Then when we say yes, then it goes to a doctor. So we are not doing any injustice to the thing. So that is one. And finally, when the report is generated, it is interpretable. The doctor is able to understand why, not just what the machine is saying, why the machine is saying somebody is positive or not, right? So for that, we have, explainability built in, where we say it is positive because there is a vascular abnormality. You see this part getting higher blood flow versus this. We also say this part of the breast has, higher metabolism. We also mark the area of the lesion so that it can be tested with an ultrasound. But I know I'm going on and on, but I've devised some 7 A's for getting community adoption for any AI model. This is my own, because I love the letter A. So, of some of them you'll all know, right? Of course, affordability, accessibility. We need to have awareness in the person. Availability. When the person says, yes, I want to get, you can't say, oh, it's available only on 1 hour of a day and so on and so forth. Availability. Accuracy, we talked about it. Adaptability, right? And sorry, acceptability. What do you mean by acceptability? The person should, the user should like it, right? The no touch, no see part of it. And so this is sort of the 5-6 A's. And when I was talking about this in one of the forum, they came in and said, oh, you also have to have a way of removing apprehension. That is, when the person comes in, you should be able to talk to the person and be able to tell her, even if it is positive, not to be worried about. They're apprehensive about what if I am detected as positive. How do we take care of the high-risk women? How you do the messaging to the high-risk women is also important. And all this will enable us to make AI adoption another 2 years across the country. Thank you.
Right. Thank you, Dr. Geeta. I think you have also answered my second question, which I had for you.
Okay.
Yeah.
I
So
didn't.
I'll bring in Dr. Meenu Singh here. So, ma'am, you have already heard about what we have been doing, and you know what's happening in Rishikesh, which is all at a very frontier of telemedicine and healthcare delivery today in the country. So, what do you see India achieving in the next 2-3 years, and in the next 5 to 10 years with respect to last mile delivery of healthcare?
So as you know, we have Ayushman Bharat program, which is already on very strong ground now. And there are more than 75 lakh 175,000 centers, across the country, which are Arogya Mandirs, which have telemedicine capability. That means they can send their patients' data across on instant evening to some hubs. It's like on the hub and spoke model. It is being adopted, like Dr. Neha had mentioned about, in different states where they have been working. And so in healthcare delivery, it is actually very rapidly catching up, because we know that technology of this type, it is catching up very fast. And even children have become aware of, some of these things. And they would, I have some grandchildren, who would like to look into ChatGPT or into Google, just to say, कि मेरे को ये हो रहा है, like, oh, my hand is red, or my fever, what am I having? So, everybody is getting sensitized. So gradually this is going to spread up, because network all over the country has increased. The bandwidth is available, and almost every household has a mobile phone now. And because of that, I think the access, as Dr. Geeta is mentioning, all her 7 A's, the access part is something which has now is there, but availability throughout the country is still a challenge. And because of lack of having too many consultants who would be available to take in the calls. So that is why you need AI assistants who would be answering those calls. You have chatbots who will be advising or counseling the patients. And but then there are certain challenges. You need to have responsible use of AI. And I would actually attach another A to the whole gamut, is that
Okay,
of
ma'am.
accountability. Is that of
Ah,
accountability.
yes. Yes, yes,
Because
yes.
sometimes you may advise something which is wrong and which is not validated, and that is why I think we're getting questions about that. But gradually, I think the system will smoothen out. The system will become more, I would say, granular, and everything is then accounted for, and general public who's using it will be quite confident of using it. So, as you said, in next 2 to 3 years, then the coverage will certainly increase. It will increase to, I guess, to all the districts of the country. And in the next 10 years or so, I think many of our operations will become totally AI based. Our day-to-day consultations, our day-to-day visits to the hospitals, that will absolutely be AI based. And that's what we think, that this use of responsible AI will also help us in detecting many of these diseases like breast cancer, what Geeta has said. There are many other cancers which can be detected and then treated. And that will ultimately improve the health of the patients. And I think by the time that Viksit Bharat comes in, AI will be in full command. That is what is expected to happen.
Right. So I think my next question will be again to you, ma'am. You mentioned that AI being in full command by 2047, right? So how do you think is especially in telemedicine, but also in general for our outpatient patient consultations, how do we build the trust? Do you think the common man will be trusting an AI doctor, let's say at a kiosk in an avatar? Do we think that our Indians in the rural setups will be able to trust AI doctors? And what should we do for
One thing
being
is
able
need based. One thing is need based. When the other doctor is not available, then the person will certainly turn to the kiosk where AI assistant is present, or when you can have face to face consultation with a doctor on a screen, where a screen consultation is available. It certainly has started working in patients who come to the hospital. They have a first time physical, consultation. They have face to face consultation. And later on, when they go home for follow up, they have no problem in talking, because sometimes it is possible even on a mobile phone where they're just talking to the doctor and they are not even seeing the doctor. But if the doctor is available to be seen on a screen, this becomes even more, people develop more confidence on that they are talking to the right person, and the right person is actually giving them the advice. Intermittently, when they are visiting hospitals in between for various interventions, that gives them a lot of confidence. But for this, we actually need integration of telemedicine with our general system of medicine, which is there. Because anytime we do teleconsultation and when they come to the hospital, these patients feel lost. I mean, these are the realities, Like when the patient lands in the hospital, or he's had a very nice teleconsultation and now he's expecting that, some assistance will be available to this person. And our hospitals are very difficult to navigate. And hence we need to have some navigational tools available in the hospitals which would guide these patients, not only in the form of some electronic tools, but also some people who are able to guide these patients in, registering, making their Abha IDs. They keep registering, linking up their Abha IDs to their records. We know that Ayushman Bharat Digital Mission is another very big program which is there. And now this app, Arogya Setu, which was there, earlier, which was devised during COVID times, it is now available for many other services, and which are Aadhaar linked, and people can actually, through the Abha ID, people can carry their health records from one hospital to another, from one state to another. And with availability of funds, because we also having this PMJ Yojana, which is Jan Arogya Yojana, in which they get at least 5 lakh rupees for treatment per person, and which is a very good thing. And once they get linked up to the whole system, that healthcare delivery and healthcare acceptance and usability becomes a very, very practical reality. So all these systems would have to be monitored very closely, because very many times, there are breaks in the system. There is a lot of vested interest also which comes into play in our country. And I think for that, we certainly need very good monitoring of all the systems which are there. I mean, AI is something which will absolutely get out of hands if you are not putting any, checks and balances on this. So that part, I think one needs to be responsible, and I guess people like you would have to devise systems in future which would look at, what is happening right and what is happening wrong, so that everything is done in a very ethical way. So this ethical and responsible use of AI is something which we are looking forward to now.
Yeah.
Thank you,
And I
Dr.
think
Meenu.
just to add to that, there was a time when patients would not trust telemedicine 10 years ago. Can I talk with a doctor over a video call? But today it's a widely accepted standard. Would patients today trust a fully autonomous AI doctor in a kiosk? I don't think they should, because the technology is not there yet. It needs more advancements in artificial general intelligence, or AGI, before that technical future is possible. So if you were to believe the trajectory at which generative AI is moving, that future might not be far off. So it falls to us. Most of these newer technologies are not going to be diffused at the technical capabilities of it, but rather at the speed of trust. How much can people trust these tools? And an essential component of trust is responsible AI. So when we are working, we've been thinking through what is the scope of what the AI tool is doing, who is the human in the loop or the human on the loop. Is the AI driving the consultation, or is the human driving it with the AI assistant? What is the intelligence level at which the AI tool operates? Is it fully autonomous, as in, analysis of an X-ray, and there's no human involved except for when the AI tool escalates it? Or is it just a decision assistant or decision support? What's the supervision architecture? Someone supervising every instance of AI use, or only are certain cases being escalated to a human, whereas the rest being done autonomously? Like, for example, medical scribes, right? So much of that work is just a transcription of the conversation. No one is really looking at every single conversation to, transcribe and add in codes, PPT codes, ICD codes. What's the fallback or the health system response? So if an error occurs, the AI to the what catches that AI generated error, and at what cadence is it catching? Often you're seeing these increase in use of large language models as judges of other large language models. So there's almost this meta level of AI supervising other AI tools. So there's so much to be done there. And then what is the trust tiers? What is the level of evidence that is needed? So rigorous validation. As Dr. Manjunath mentioned, that doing randomized control trials, comparing the accuracy of these tools with the current standard of care, or even perhaps a higher standard, because in some cases these tools might surpass the current standard of care. And so, do you do a prospective deployment, a pragmatic trial, case vignettes? Do you do an actual patient? So, there's so many different methodologies beyond just randomized control trials to arrive at the level of trust. So I think those are sort of the big key themes that we think through when we're
Right.
thinking of this kiosk doctor in a kiosk future.
Right. Thank you. So, Dr. Meenu Singh has another meeting at 4, so she'll need to drop off. But thank you, Dr. Meenu, for joining and delivering a very inspiring and
Thank you.
insightful keynote. Maybe
Thank
we
you,
can,
everyone. Thank you.
yeah. Maybe Dr.
Okay.
Neha and Dr. Geeta, if you have some time, we can answer
Yeah,
some questions from the audience.
Sure.
Yeah.
I typed in a few answers. If there are any live questions, happy to take it.
Yeah. So we have one question, and I think this is very relevant. Is that how are we actually grounding and evaluating these AI tools, especially in CDSS? And I think, Dr. Neha, if you want to come in, for CDSS, there are like different metrics, different ways of evaluating them. What is the current gold standard for doing that?
Yeah, so, contextual grounding is extremely important. The This was before you go do evaluation. There's a lot you can do in the development phase of AI, of the clinical decision support tools, to make sure your tools are well grounded, making sure there's a good diversity of population. You're looking at different geographies, different case presentations of disease you have brought across in your data sets, that every possible sort of variety. So before you even move towards evaluation, when you think about grounding and contextualization while you're developing, maybe sit down and note what are all of the possible sources of diversity that might exist in this data set, from early stage disease to end stage disease, different presentations, morphologies, genetic variations, if you're using that. So, and then ensure that your data set captures all of those. If you're using large language models, there are tools like retrieval augmented generation, graph RAG, disease ontologies. All of these are ways to contextually ground. If you're using an agentic AI framework, you could put constraining boundary conditions to ensure agents don't go beyond certain boundary conditions. You could have a maker checker process a second LLM, checking the work of the first. You could have a council of LLMs approach. So there are many technical approaches in the development phase. And then in the validation phase, ensuring that you're doing a very thorough, what we like to start off with a failure modes and effects analysis. It's a standard in physical medical devices, and clinical decision support systems are but another form of software as a medical device. So the same degree of safety checks you would do for a physical medical device apply here. So, if you look at the ISO standards, the failure modes and effects analysis basically says, what are the various ways in which my tool can fail? What would be the effect of that failure, and how do I mitigate that effect? Uh, the thing with software, or with software decision support systems, is you might not be able to fully mitigate every sort of failure, because there isn't like specified this nut is going to break or this sensor is going to break, right? You have lines of code, sometimes hundreds of thousands of lines of code. And so you also have to put in safety practices at time of software development. Are you writing good PRDs? Are you doing peer reviews? Is there proper code audit and review happening? So all of those ways. So these are all before we even get to clinical trials. And then you have your clinical trial. Typically, you'll do some kind of phase one clinical trial on case vignettes, not real patients, but maybe simulated cases, simulated data where the ground truth is known. We have found that it's really hard to establish strong ground truths. And that always, is perhaps the biggest reason that contributes to the cost of building these AI systems. Establishing a solid ground truth for validation.
Absolutely.
You could
Absolutely.
then, after having the some kind of maybe case vignette, then you do a phase one trial with actual patients, again against a validated ground truth standard. And then finally, perhaps you do in um in actual practice effectiveness studies, efficacy trials. You should also look at acceptability and usability of the tool. If someone is not trusting it or accepting it, what's the point of having a very accurate tool that is not accepted by users? So these are just some of the kind of framework when you're thinking through validation of AI tools. Again, I would say like establishing gold standard is perhaps the one of the hardest aspects of these validation exercises. And as soon as you're able to establish a good gold standard, you're able to kind of use that as comparison of AI assisted output or AI generated output versus human alone without any assistance or support.
Right. We'll have one final question, and I think Dr. Geeta can take the question. Also, like there are a lot of questions in the chat regarding collaboration, reaching out to us. So I think you can just go on LinkedIn and reach out to us if you want to
Yeah.
partner or collaborate. That should not be a problem. So this question is that AI tools model drift, right? That is something which we like see very frequently, model drifts, dataset drifts. So you have already deployed it in your like different places, right? So how do you go about that, and what are the challenges which you are faced, like deploying these and facing model drift? How do you look at these changes which you have to do to your model to ensure the accuracy and sensitivity remains?
Yeah. So the model drift can happen through multiple reasons, right? So you're adding different, let's say you're trained with some set of samples, and then sort of you're suddenly getting completely a cohort of patients uh, who are not in the same distribution of the training set that you used to build the model types, right? So, and how that happens, can be because of same country, different country, same age group, different age group, several sort of, for example, in the breast case, benign conditions coming in. Initially, we saw like, pregnant ladies when we come in, the first, like 7 years back, right? When pregnant lady incoming, we were calling them out as, red, right? Obviously we knew it is not. And so we used to sort of have a layer of saying, oh, pregnant lady, ko nahi ka problem. Because the vascularity and the milk ducts were kind of, not confounding. We were actually catching the milk ducts rather than the vascularity. So all those things, right? So essentially the drift, first of all, unlike, for example, in other cases, like, I've worked in so many other areas as well, like say market conditions or customer calls, etc., where the drift is actually happening in the environment, right? People know more, so they may ask different questions, things like that. Here, the body is behaving the same way. So as healthcare people, we have control on the model drift. Only thing is you have to ensure that the place where you are testing your model or using your model um, um, the distribution of that place, right, is already taken care of in your training. So it's kind of more controllable in that sense. For example, if you want to go to US, then you have to ensure that your model is trained with some US samples put in it. And so that is what I mean by controllable, right? So yes, how do you ensure? Obviously, sort of, first of all, how do you know that the model needs to change? Things are drifting, right? For that, you need to have sort of, at least intermittent clinical studies. Okay, I've done 3 years back, done no more clinical trials, just do production. It is feasible, but you may end up having some false positive, false negatives more than what you earn. So what we generally do is almost, though we have tested so many, right, so many studies we have done, if a new doctor, KOL wants to do a small study, we will enable that. So we continuously start, do this sort of checking with the reference test every year, every 2 years, every 6 months kind of thing. So then we will know whether the false negatives, there are new false negatives, new learnings, new data samples that are appearing, which needs to go back to the training set. Let's say now we've figured out which are the new data samples that need to go into the training set through these additional clinical studies. Because in production, you don't know what is the reference test for it, right? Unless the lady comes back and says, oh, I did an ultrasound and it was negative, whatever. That also happens. And then actually, that's what I was saying, because we are ISO 13485 and the AI, one of them asked this question. It is AI models are learning, but they're learning in a controlled environment, not on production. Hey, somebody said there's no positive, so immediately change the model live. That can be done technically. We all know how to write those AI models, but that's incremental learning and all. But we can't do that for healthcare, especially for CDSs. So we come back to your sort of, R&D hub, take up those samples which you think need to be added to the training set, retrain the model. You may want to evolve also, adding new features into it, because, we generally do that, especially in the early days, a lot of false negatives or a lot of false positives, whichever way, then you kind of cluster them to see what are those new features we need to add so that we can reduce those, right? So you enhance the model itself. So it's not just enhance the data, enhance the model also. Of course, just simple deep learning models are all it's not suitable for healthcare alone, or not suitable for healthcare alone. So you need to do some handcrafting. That's a separate topic. We'll come to that. But in this particular case, when you learn again, you have to test it. And as I was earlier mentioning, it is tested just like a software is tested, with a regression test of test plan, whatever, all of that, including a regression set of samples. And then only when you're sure the sensitivity and specificity is not or it's more than the previous one, we release the model. So it's way that is a very controlled, locked environment. But yes, it allows the increment. And this whole process is actually reviewed by our, regulatory people who come in, right? Because it's very important to get and first of all, adhere to the processes and get audited for that, so that, you can prove to the world that you're doing the right thing. You're muted.
So thank you so much, Dr. Geeta, and thank you, Dr. Neha, for joining. I think we are almost 15 minutes past the closing time.
Okay,
So
yes.
we thank the audience, a fantastic audience. More than 120 people had joined, and hopefully you can take home some insights from the fantastic work which our panelists and speakers have been doing. And we hope to see you in the next webinar, which is again on the first Wednesday of August.
Okay. Thank you so
Okay.
much for the opportunity. Thank you. Nice meeting you. Neha.
Wonderful.
Bye-bye.
Thank you so much. Namaskar.
Bye. Namaskar. Bye.
Bye.
Bye, everyone.